Mm-hmm. Good, good evening. My name Ola Ann, and I'll be presenting on pathogenesis and management of peritonitis. So our outline. So peritonitis is defined as either an acute or chronic inflammation of the peritoneum, and the peritoneum is the membrane that lies the abdominal cavity and covers the viscera. So this inflammation can either be localized or generalized, and mostly 10% of the deaths are usually as a result of bowel obstruction. And the causative organism is a pyogenic bacteria, E. coli, aerobic and anaerobic staphylococcus and streptococcus. So the epidemiology. So the incidence varies based on underlying conditions, e.g., could be appendicitis or a perforated visceral. It is common in both community and hospital settings, particularly in immunocompromised patients. And there's a higher prevalence in developing countries due to infectious causes. So classification of peritonitis. So peritonitis can be classified under 4. It can either be anatomical classification, etiological classification, pathological classification, or clinical classification. So for anatomical classification, it's subdivided into 2. We have the localized peritonitis or diffused or generalized peritonitis. So for localized peritonitis, it refers to a loculi of infection, usually walled off or contained by adjacent organs. And loculi means it is to a specific area or part in a cavity. And factors that are favorable for localized peritonitis includes anatomical factors such as compartmentalization of the peritoneal cavity. That is, the peritoneum compartmentalizes each organs, and due to the compartmentalization of the peritoneum, it makes it easier, or should I say it's better, because it makes an infection to be just to a specific area. And we have pathological factors such as the omental wall. So the omentum hangs off from the peritoneum, and it can extend in cases of an infection to help encapsulate the infection and prevent it from spreading to other parts. And then you have surgical factors such as the use of drain, which can help in localization of the infection. So diffused or generalized peritonitis, this one refers to the spread of the infection to the entire peritoneal cavity. Unlike localized peritonitis that is just to a specific area, for generalized peritonitis, it spreads all over the peritoneal cavity. And factors favoring generalization is sudden visceral perforation, such as perforation of the appendix, violent peristalsis, ingenious handling of localized collections, immunocompromised patients, and children that have small omentum. And be wondering, why do children that have small omentum are more likely to generalize peritonitis? That's because the omentum cannot spread to cover. The omentum helps in fighting infection, helps in fighting the spread of infection, because it can cover up the organs and encapsulate the infection and prevent it from spreading. But for children that their omentum are small, it will not be able to cover a wide area. Hence, there will be generalized peritonitis. So etiological classification, that means the causes. Under etiological classification now, we have bacterial peritonitis. It is caused by introduction of a bacterial infection into the peritoneal cavity. For chemical or aseptic peritonitis, it is caused by introduction of a chemically irritating material into the peritonitis. That is such as pancreatic enzyme or rupturing of the gallbladder and releasing bile. And then you have non-bacterial peritonitis. It's caused by non-bacterial infection, either fungal or a virus. And then for pathological classification, it's subdivided into 3. You have primary peritonitis, secondary peritonitis, and tertiary peritonitis. So for primary peritonitis, it is a spontaneous bacterial invasion of the peritoneal cavity occurring in the absence of an apparent intra-abdominal source of infection or pathology. It commonly occurs in infancy, early childhood, secretic patients, or immunocompromised patients. They are usually caused by monomicrobial infection, predominantly Streptococcus pneumoniae. For secondary peritonitis, it is described as peritoneal infection resulting from the loss of integrity of the GI tract due to GI perforation, anastomosis, deafness. So for people that wonder what is anastomosis deafness, is the failure of the surgical connection between two structures to remain closed, and this can lead to spread of infection. Typhoid fever, infected pancreatic necrosis. And for secondary peritonitis, it is the most common form of peritonitis encountered in clinical practice today, and it is usually caused by polymicrobacterial infection, mainly aerobes and anaerobes. An example is the E. coli. So for tertiary peritonitis occurs, it's like a reoccurrence of after treatment of both primary and secondary. So it presents as the persistence or reoccurrence of a peritoneal infection following apparently adequate therapy of spontaneous bacterial peritonitis and standardized patient therapy. So tertiary peritonitis develop more frequently in patients with significant pre-existing comorbid conditions, immunocompromised patients, and is usually caused by gram-positive and gram-negative bacteria and fungal infection. For clinical classification of peritonitis, it can either be acute or chronic. So for acute, it's the clinical presentation of a sudden onset with abdominal pain associated with anorexia, vomiting, fever, and abdominal rebound tenderness and rigidity. And the bacteria that causes usually bacterial peritonitis. And chronic peritonitis, it presents with gradual onset of abdominal findings and can present with weight loss. And the bacteria is usually TB peritonitis, which stands for tuberculosis peritonitis. So for the etiology or cause, it's usually caused by three main things, either bacterial peritonitis, chemical peritonitis, or non-bacterial peritonitis. So for bacterial peritonitis, it is caused by introduction of bacterial infection into the peritoneal cavity. Now, the perforation of a hollow viscous is the most common cause of peritonitis. Examples include perforation of the stomach due to peptic ulcer, gastric carcinoma of the duodenum, or intestine, e.g. due to appendicitis, diverticulous, or anastomotic leakage. So disruption of the peritoneum, even in the absence of a perforation of a hollow organ, may also cause infection simply by letting microorganisms into the peritoneal cavity. And how can these microorganisms get in? It's through trauma, surgical wounds, and drains. So spontaneous bacterial peritonitis is a peculiar form of peritonitis occurring in the absence of an obvious source of contamination, and it occurs in either children or patients with ascites. Chemical peritonitis. Chemical peritonitis is caused by introduction of chemically irritant substances such as gastric acid due to perforated ulcer, bile due to perforated gallbladder or lacerated liver, blood due to ruptured spleen or ectopic pregnancy, urine due to ruptured urinary bladder, and meconium peritonitis. So meconium is the first stool of an infant. So when the first stool of a newborn, so in a condition that occurs where the first stool of a newborn lives into the peritoneal cavity, can cause meconium peritonitis. And it is important to know that while these body fluids are sterile at first, they frequently become infected once they leak out of the organ containing it, leading to infectious peritonitis within 24 to 48 hours. So for non-bacterial peritonitis, this is caused by non-bacterial infections of the peritoneal cavity, such as fungal peritonitis, viral peritonitis, and chlamydia peritonitis. Now, pathogenesis. Initially, peritoneal inflammation is often localized, and the affected area contained by a wrapping greater omentum, adjacent bowel, or fibrous adhesions. If the inflammation focus is part of an ongoing process, or if the host defenses are lowered, localized peritonitis may progress to a life-threatening generalized peritonitis. There is a massive exudation of inflammatory fluid into the peritoneal cavity, causing hypovolemia, often compounded by toxemia from absorbed products, and sepsemia if infection presents. Diffuse peritoneal irritation can cause peristatic paralysis with a cessation of bowel motility. Thank you very much. So for management, it will be presented by Precious Uju.
Good evening to my consultants, residents, and fellow colleagues. Sorry, please let me share my screen. Okay. So management. So the history. A patient with peritonitis typically presents with the following symptoms: abdominal pain. The nature of the pain is often severe, constant. Some patients may also often describe the pain as sharp or aching, worsening with movement. Pain usually intensifies with movement, coughing, or even deep breaths. Patients with peritonitis often pass the cough test during examination. Also, they also present with fever and chills. A rise in temperature due to infection and inflammation is common, often accompanied by chills. Management, nausea and vomiting. Patients frequently experience nausea and may have vomiting, which can exacerbate dehydration and electrolyte imbalances. Distension, due to fluid accumulation and reduced bowel movement. Patients usually report abdominal bloating. Change in bowel movement. Patients may experience constipation, in some cases diarrhea. Paralytic ileus or temporary cessation of bowel function is also common. Difficulty in breathing. In severe cases, distension can cause difficulty in breathing. Patients also complain of loss of appetite and anorexia and also aversion to food. On examination, there is abdominal tenderness. There are three types of abdominal tenderness which are noticed. Generalized tenderness. Pain is often elicited with light palpitations across the abdomen. Then local tenderness. If peritonitis is secondary to a specific organ, such as the appendix, gallbladder, tenderness may be more intense in that area. Rebound tenderness, which is also called Bloomberg sign. Increased pain upon sudden release of pressure on the abdomen, indicating peritoneal irritation. Guarding and rigidity. Involuntary tensing of the abdominal muscles occurs as a protective reflex to avoid irritation of the peritoneum. The abdomen feels firm or board-like. It is associated with acid peritonitis. Reduced or absent bowel sounds. This can suggest ileus due to inflammatory process or paralytic ileus. Signs of hypotension and shock. The pulse may be rapid and of poor volume with hypotension in shock. Elevated heart rate and temperature are common signs of infection. In some severe cases, dry and inelastic skin and sunken eyes can be observed. The tongue may also appear furred or coated and dry. These are signs of significant dehydration and systemic illnesses, which can result from prolonged infection, fever, and fluid shifts. On rectal examination, you may experience some tenderness in the rectovesical or retrouterine pouch and in amoeboracic granularity and edema of the rectum are felt. Diagnosis is usually clinical. Investigations. So to diagnose peritonitis, you do some certain tests. We have laboratory tests. We also have imaging, and then paracentesis. So in laboratory tests, you do a complete blood count, usually indicates an elevated white blood cell count and due to infection or inflammation. They also do blood cultures. It helps to identify the causative organism if sepsis is suspected. In the case of a bacterial infection that's causing the peritonitis. Then blood chemistry, the serum electrolyte, blood urea, pH, the partial pressure of oxygen, partial pressure of carbon dioxide are done and abnormalities are corrected. In the early stages, the serum electrolytes was essentially normal in spite of the considerable loss of water, sodium, and potassium and chloride because of fluid that is lost with ECF and isotonic with plasma. Like you lose your electrolytes due to like dehydration, probably vomiting or diarrhea. Imaging. Abdominal X-ray can reveal free air under the diaphragm if there is a perforation such as perforated peptic ulcer causing secondary peritonitis. In paralytic ileus, the entire gut is dilated and fluid levels are evident. Ultrasound, useful for detecting fluid collection or abscesses, particularly in localized peritonitis. CT scan of the abdomen, highly sensitive and help identify the source of infection, fluid collection, perforation, or any underlying pathology. Then the fourth one, that's paracentesis, that's the four-quadrant peritoneal tap. In doubtful cases, a four-quadrant peritoneal tap may aid the diagnosis. A turbid is like a clear, whitish or purulent aspirate establishes the diagnosis, and bile-stained aspirate suggests a perforation. Sorry about that. So, suggest a perforation. The aspirate is cultured and sensitivity test done. A negative tap does not include peritonitis. Treatment. The treatment of peritonitis involves interventions to address infection, control inflammation, and prevent complications. Patients should be optimized, and here is how. We have supportive intervention, and then we also have surgical intervention. In supportive intervention, we have restoration of fluid and electrolyte deficit. It is of cardinal importance that fluid and electrolyte deficits are corrected before operative intervention. Aggressive fluid replacement is necessary to manage dehydration and counteract shock. If hypotension is absent or not severe, Bringer's lactate, which has the same composition as ECF, is the fluid of choice, especially as there may be acidosis. For normal saline or dextrosaline may also be given. If hypotension is severe, a liter of plasma substitute should be given to raise the blood pressure before continuing with crystalloid. Blood may be given if anemia is present. Nasogastric decompression. A nasogastric tube is passed and the stomach is aspirated frequently. The aspiration should be replaced with gastrointestinal replacement solution. Decompression not only reduces the distension of the abdomen and the pressure of the diaphragm, thereby making breathing easier, but also helps to keep the gut to retain its tone. Usually during a patient with peritonitis often has difficulty in breathing due to distension of the stomach. So the nasogastric tube would help to relieve the pressure in the stomach, which will aid and help in breathing. Pain management. Petidine 100 milligram or morphine 10 milligram is given to relieve pain and anxiety. It should be administered cautiously to relieve severe abdominal pain without masking symptoms. Administration of antibiotics. Broad spectrum antibiotics initiated as soon as peritonitis is suspected to control infection. The choice depends on likely the causative organism, e.g., gram-negative and anaerobic bacteria, and whether the peritonitis is primary or secondary. IV antibiotics administered intravenously to ensure adequate blood and tissue levels with adjustments based on culture results. It's very important to also do a test of, I'll talk about it later. Treatment of underlying cause, if applicable. For example, if peritonitis is secondary to liver disease, as a spontaneous bacterial peritonitis in patients with ascites, additional treatment to manage the liver disease and prevent reoccurrence may be required. Prompt initiation of this treatment is essential, as untreated peritonitis can lead to severe complications, including sepsis and multi-organ failure. Peritonitis of pelvic organs. Sorry? Hello? Peritonitis
Please
of
continue your
pelvic
presentation.
Peritonitis of pelvic origin should be treated conservatively, as most cases settle on such treatment. Residual abscess are drained later. Surgical intervention. Exploratory laparotomy or laparoscopy surgery can be necessary in secondary peritonitis to identify and repair the source of infection, such as a ruptured appendix, perforated ulcer, or bowel perforation. Drain of abscess or infected fluid collection, drainage of abscesses. If abscesses or fluid collections are present, they are typically drained surgically or percutaneously under image guidance, that's ultrasound. Drains are not usually inserted, as they introduce more infection and tend to erode vessels and even the guts. Prognosis. It depends on several factors. In the duration, the longer the period of the peritoneal soiling, the graver the outcome. Prognosis is good if the treatment is instituted within 12 hours. Age of patient. Peritonitis is very serious in the young, with small momentum and less effective localization of infection, and delay in diagnosis. And in the aged, with poor general resistance and often pre-existing diseases, pre-existing illnesses. A previously healthy patient will tolerate peritonitis better than who is already ill. A typhoid patient who is already very ill does not stand preparation well. Level of preparation. Preparation of large bowels, because of very virulent and teeming organisms in the large bowel, is more serious than preparation of the stomach or duodenum, in which bacterial invasion takes long to develop. Multiple organ failure. It is very high. It has a very high mortality. Follow-up. Monitoring for infection reoccurrence. Regular blood checks and physical examination should be done to track recovery or detect any new or recurring infections. Management of drains, if any. Drains need to be monitored and flushed until there is minimal or no output, at which point they are removed. Antibiotics costs and conclusion. If oral medications were prescribed, ensure patients complete the prescribed course. Patient education. Encourage a healthy diet, hydration. Educate on signs and symptoms that may indicate reoccurrence. In conclusion, peritonitis is a serious and potentially life-threatening inflammation of the peritoneum, typically resulting from infection due to underlying conditions like perforated organs, bacterial translocation, or spontaneous bacterial infections, especially in patients with liver disease. Clinical signs such as abdominal pain, guarding, rebound tenderness, and systemic symptoms like fever and dehydration help in early detection, while laboratory test imaging and peritoneal fluid analysis confirm the diagnosis. Treatments requires prompt, often aggressive management with antibiotics and supportive care, while severe cases or those with secondary peritonitis often necessitate surgical intervention. With timely diagnosis and appropriate treatment, many patients fully recover. However, untreated peritonitis can lead to complications like sepsis and organ failure, emphasizing the importance of early recognition and intervention. Comprehensive follow-up is crucial to prevent recurrence. These are the references. Thank you.
Thank you for your presentation, Dr. Ene and the other person. So we'd like to move to questions, contributions, clarifications. So anyone that has questions, clarifications for the presenters? You can simply unmute yourself to ask, please, or to contribute. Okay. Okay. Thank you, doctors. And I'll make my contribution since no one has anything, and ask my questions. Dr. Ene and sorry, the other doctor, what's your name? The other presenter.
Dr. Precious.
Okay, Precious. Okay. Thank you for your presentation. You did very well. It was detailed.
Okay.
I just have a few contributions to make. For the pathophysiology, that's Dr. Ene's side. You stopped at the infection being localized, being generalized in the abdomen. You didn't talk about the pathogenesis exceeds the abdominal pathology, because it's more of like a systemic disease, right? So once it has become generalized peritonitis, the patient can eventually suffer sepsis or systemic inflammatory response syndrome first, sepsis, multiple organ dysfunction syndrome, and death if left untreated. So it's very important to note it when you talk about the pathophysiology, because it's a whole spectrum from the least effect to the maximum effect, which is death. So it's quite important to mention it. Then part of your management under your treatment, you didn't talk about usually we are supposed to follow the ABCDs of resuscitation. So first, you mentioned them, but they were not arranged as it should be, I guess. So you ensure airway, because most times the patients have splinting of the diaphragm from if the peritonitis is severe. So they have impaired respiration. So you want to support them. So once the patient is talking, you know that the airway is patent. For breathing, that's when you will notice maybe the patient is tachypneic, is desaturating. So you will need support of respiration by either administering oxygen via intranasal oxygen supplementation or the rest. Then we'll now go to circulation, which is C. So under circulation now, patient has peritonitis, patient is losing fluids, is having electrolyte derangement. So the first thing you should do, you will insert 2 wide bore cannulas. Collect your samples for full blood count, EUCR, grouping and cross-matching if necessary. Then you also put a urethral catheter. That is very important because it shows, it helps you monitor the patient throughout resuscitation. So you've passed your urethral catheter, monitor urine outputs hourly. Then you talked about NG tube. That's also a spectrum of the circulation. So we'll now go to, okay, you talked about antibiotics, diagnostic peritoneal paracentesis. Okay. So, most of these patients usually have severe electrolyte derangement. The most pronounced is potassium hypokalemia because of the leakage of accumulation in the peritoneum. So patients usually suffer hypokalemia. So it's one of the things you should watch out for by electrolyte urea and creatinine, and you correct after ensuring adequate urine outputs. For pain management, you talked about pethidine and morphine. I think we can start with there is a ladder for analgesia or for pain management. You can start with, because these patients, for instance, now they are giving them analgesia might help, but the primary pathology is most times surgical. So supplementing or pain management can be started with probably paracetamol, non-steroidal anti-inflammatory drugs, depending on the pathology, before you now go to pethidine and morphine. Then drains are not absolutely contraindicated. I think you mentioned that drains and should not be used in cases of. So following exploratory laparotomy, depending on your findings, depending on what you find when you explore the patient, you decide for or against a drain. Most advocacies are for drain because a patient with peritoneal contamination is at risk of further contamination following surgery. The patient is at risk of having recurrent peritonitis or collection, intra-abdominal collection, abscess collections, for instance. So you want to pass a drain to help, in case it forms, to help drain those abscesses to prevent a generalized peritonitis from forming. Then you didn't mention complications. Anyway, I think I've mentioned them in the pathophysiology. But it's always important to actually list them out so that it looks like you know what you're doing. So for localized complications or abdominal complications, patients can suffer paralytic ileus, can suffer residual or recurrent abscess following surgery, portal pyemia, adhesions from small bowel. Patients can subsequently develop adhesive small bowel obstruction later in the future. Systemic complications can be septic shock, as I mentioned, systemic inflammatory response syndrome, multiple organ dysfunction syndrome, and death. So those are the few contributions, I think. Then I think for pronunciations, I think you guys have the presenters today. Pronunciation of some of these medical words is quite important because during orals, for instance, you want the examiner to understand what you're saying. So when you're in doubt of pronunciation, I think you can just check Google Pronounce. It will tell you the adequate or the appropriate way to pronounce a word. That's just a little extra for you guys. I don't know if Dr. Bashir will not, I don't think he's present. So is there any other questions? Hello, Dr. Ola, Dr. Ene, any clarifications?
Hello, good evening, Doctor. Doctor, good evening. You mentioned
Yes.
something about post-op or later patient is likely to suffer, I think, adhesion, the intestine adhering together, something like that.
Yes.
I just wanted you to
Yes.
throw more light on that.
Okay, so when there is, I think the presenter explained it, when there is inflammation in the peritoneum, there is fibrous deposition or fibrinoid exudate deposition. So these fibrin bodies, you know what fibrin is, right? So these fibrin bodies that are part of the inflammatory response eventually can, depending on the degree of inflammation, would form bands, adhesive bands, you understand, between the bowel segment itself and even the peritoneal cavity that could predispose this patient to adhesive intestinal obstruction, which is a form of extrinsic compression of the bowel loops. Do you understand? Hello?
Yes, I understand. But your explanation, it seems
Okay.
as if it's not, I'm asking for the post-op, or were you explaining just the pre-op, that's before the surgery?
Okay, you know, the inflammatory process spans even from preoperative to postoperative, because having surgery does not mean the inflammation will just disappear. It takes a while for the inflammation to resolve gradually, especially when there is peritoneal contamination with those microorganisms. So the inflammatory process is still there. It's just that you have contained it and prevented it from progressing. So it doesn't entirely stop adhesions from occurring. Do you understand? Surgery does not
Yes.
entirely stop adhesions from occurring. It just controls it or minimizes it.
Okay. Okay,
Yes.
I
Yes.
get it. Thank you very much.
All right. Any more questions, contributions? Okay. So in the absence of any, would come to the end of today's presentation. Is there anybody is there any presentation happening tomorrow? Because Bashir said 4. Is there anyone presenting
Yes, ma'am.
tomorrow?
Yes, ma'am.
Yes.
Okay, what topic? Hello?
Pathogenesis
What is
and
the topic?
management of acute appendicitis.
Okay. So we'll be meeting by 8:30 tomorrow.
Okay.
Yes, ma'am.
All right. Thank you all. Good night.
Good night, ma'am. Thank you, ma'am.
Mm.